So first, there are a whole bunch of ways things might slow down. We're all in our various homes right now, so the internet loves us up. I assume most of you are as well. If you need to dial in, the dial-in number should be in the invite, and Robert has put it out in the chat box. We're doing something different this time. So for questions, you can submit your questions via the Q&A, and this is going to be a bit of an experiment for us. Hopefully it'll work, but you can put your questions in there rather than in the chat box, and we will try to answer them. We'll see how well that goes. We do have our regular webinar coming up, and that, I believe, is on April 15th, the formerly known as Tax Day. Breyer Andreessen and Ryan Johnson are going to be doing that webinar. Katie, help me out. It's
on interoperability, which is the giant, maybe people think it's terrible, I think it's terrible, final rule that came out pre-COVID that's going to be super complicated. And so Breyer and Ryan are taking a first cut at that.
So those kind of procedural things to do. Actually, I'll also just mention this webinar is recorded. And so at the end of this, if you decide it was useful, or if you have to go in the middle, if we run long, you can probably sometime Monday or Tuesday, you will be able to watch it. Okay, now let's just dive in. So first, I'm David Glaser. I've got two colleagues with me. Katie.
Hi, I'm Katie Ilten.
And Margie.
Hello.
So we are going to walk you through the regulatory updates. And we had our webinar about 2 weeks ago. We're not going to rehash much of the stuff in there, although I'm going to start off with one point. There I talked about how you run a red light when there's a tornado coming. And this regulatory principle is a key one. If you're sitting there and you see something like this, sometimes you have to make snap judgments. When we were driving back from the solar eclipse back on August, was it the 20th, I think, or August 19th in 2017, we were driving home from having seen the eclipse, looked up and saw this. I was driving, so the picture credit goes to our son Zachary, who took this picture through the sky roof of what was a developing tornado. And we were not storm chasing at the time. We were literally just driving home and went through a thunderstorm that wasn't supposed to be severe. And we looked up and you saw that. And when you see something like that, you have to make sort of a snap decision. What am I going to do? The answer was definitely not pull over and wait there. It was get the heck out of Dodge. And you're going to be in a bunch of unforeseeable situations right now where the answer isn't going to be clear. If you've got time, we're happy to help you sort through it, but sometimes you're going to have to make a snap judgment. Make it and feel comfortable with it. We're living in a time, some people would say there's a Seinfeld for everything. I think there might be a Gary Larson for everything. And there's a Gary Larson for this, right? And I don't think this is how the whole thing started, but it feels that way at times. And we're in a strange land right now. Now, CMS has come up with a whole bunch of new rules. And we sometimes are critical of the government. I am. I need to give credit where credit is due here right now. They have done an amazing job with these things. We, in the course of the webinar, are going to make fun of a few things. We will point out places where the rule doesn't make sense or where we would have done it differently. That should not be viewed as a criticism, because I think in a short amount of time, the folks at CMS have done a ton of work, and it is clear they are trying to make life easier for people. And so I want to give them kudos. And I think that it's important not only to just say thank you, but also because there's a spirit here. They have not fixed everything yet, but more fixes are going to come. And one of the things to note as we talk about the various rules here, they're usually predating or post-dating rules, backdating rules, I guess would be the right way of putting it. So that if they issue guidance on March 20th, that might be effective March 1st or January 1st. And so there are a couple of things that has impact in a few different ways. So first off, you'll want to track something. If something isn't billable right now, realize it might become billable in 3 weeks, and that might relate back to now. So if something becomes billable, you want to be able to bill it. Second of all, you might, in some instances, take a chance and say, we don't have an explicit permission to do this, but we're going to assume that that permission is going to be there at some point, and we're just going to do it now. We can always choose to refund later if we want, or, so we're going to bill it even though it's not crystal clear. And we'll talk about some very real-world examples of that. All of my colleagues and I have had to kind of make stuff up on the fly this week. Okay, so there are waivers that have been issued by HHS. There are waivers that are issued on the state level. Some of them are real waivers. But one of the frustrating things here is sometimes something is called a waiver and it's not. We're going to talk in a minute about the Stark and its blanket waiver. It ain't no blanket waiver, all right? So the real waivers truly get rid of a rule. There are also waivers that are merely permission to ask for a waiver. I have no idea why those are called waivers, but they are. We're going to talk a little bit about the CARES Act. That's a congressional act that came out a week ago, a little more, that made a whole bunch of legal changes, but primarily they were economic. It's creating money for a bunch of things and changing rules. The Medicare rule impact is relatively small. There are a couple, Katie Ilten will talk about them. One of the biggest things it did is created a pot of money for small organizations that have 500 or fewer employees. And Margie is going to talk about those at the end. If you have fewer than 500 employees, hopefully you already know about some of those opportunities, but if you don't, you're going to want to stay to the end, or if you can't stay to the end, listen to the recording and catch Margie's explanation of that, because it may save your existence. I have state law still matters on here as a question mark and an exclamation point, because it's both, right? Does it still matter? And wow, we need to pay attention to it. And that's completely inconsistent, but it's how we're at right now. One of the questions we got for today was, hey, we've got these contradictory waivers, right? There's two federal waivers that might apply. There's a state waiver. Which one do we listen to? And the first thing is that federal waivers and state waivers are totally different, and you can have a situation where the federal government will let you do something and your state will not. And that might sound a little crazy, but if you think of it, that happens all the time, right? Medicare might cover a service, but a state licensing board may say we think it's out of this particular professional's scope of practice. That can happen in normal times, and it can happen now. It's just a little more frustrating now because the pace of change is so high, but you do have to know what's happening on both the state and the federal level. If you do have two waivers, if there are two federal waivers on something, I think you get to choose the one that's broader, right? Because the fact that a second waiver came out, waivers will eventually expire, or they'll end when the emergency ends, but if you get to choose the broader of the two. But don't think that a federal waiver helps you on a state law issue. And then we've stuck this on a bunch of the slides, but remember, most of what we're going to talk about today only applies during the emergency. So don't assume that anything we say today is good when we come out on the other side. Here are a bunch of links. I won't explain all of them, but what they are in broad strokes. There is the first one is a page at CMS that is a great landing page on sort of all of their waivers. And so it's got it by various areas and by topics. Good place to go. The next two are acts, the first sort of COVID bill and the second COVID bill. And then we've got links for the Stark waiver and EMTALA. All right, Katie is going to walk us through some acronyms.
All right, everyone. So we tried to list some acronyms that are new-ish to COVID in here. And the first kind of important one is the PHE. We're going to use that throughout, and it's the acronym that CMS uses in its final rule and in a lot of other guidance documents. So PHE stands for Public Health Emergency, and obviously in this case it's COVID-19, and it's a time issue. So PHE, the public health emergency began when President Trump declared it as such. So that's the date for, and I'm blanking on the date, I think it was March 6th. I'll swing back with that in a bit. But PHE is the current COVID emergency that we're talking about. So that's going to be important because it's duration for many of these temporarily waived rules. The next one is IFC, and in a world that's irrational right now, true to form, CMS has been irrational with this acronym. IFC stands for Interim Final Rule with Comment Period. And despite my urge to want to correct it to IFR, we've left it as IFC because that's what CMS has used. And we've also added the third acronym, WTF, as a comment on IFC.
Isn't IFC the Independent Film Channel? Because that's what it is to me.
It's not the interim final rule is what I have to say about that. And then CTBS is Communication Technology-Based Services. This isn't really a COVID term, but it's fairly new in CMS land, and it's going to be important when we're talking about the distinctions between telehealth, the capital T, the Medicare version of telehealth, and what's paid as, quote, telehealth, and then what is paid as non-telehealth, but is still like remote and technology-based communication, which are described as communication technology-based services.
So, Katie, my gig here is going to be to keep interrupting you with jokes, and I will just say on this one, I'm too much TV watching. To me, CTBS is a commercial to watch a television network that I think might be gone, Turner Broadcasting Systems. My entertainment jokes will stop now.
Jake, David's jokes will hopefully only last the duration of the public health emergency. And then IRFs, Inpatient Rehab Facility, a couple other ones that are out there, home health agencies. If you see one that we didn't list, just shoot us a note and we'll call it out for everyone.
All right.
And I'll just interrupt David now with a non-joke. Margie just reminded me that the public health emergency was declared March 13th, 2020. So
Friday the 13th.
So that's an important date.
That's fitting.
Yes.
That's perfectly fitting.
That's fitting.
We'll remember that now. All right, so I'm going to talk for a couple of minutes about Stark. And the first thing to keep in mind on Stark is they call it a blanket waiver. And as I alluded to at the opening, don't be trapped by that, because it is a blanket. This blanket will not keep you warm at night. So here's one of the quotes. For a blanket waiver of Section 1877, so that's the site for Stark, is limited to circumstances described in the individual blanket waiver, and healthcare providers must satisfy all of the conditions of the blanket waiver in order to rely on the blanket waiver. So I don't know how your brain works, but the way my brain works is if there was a blanket Stark waiver, you don't have to pay attention to Stark. That ain't it at all, okay? So instead, if you've got remuneration, which is pay, or referrals that are solely related to COVID-19 purposes, you might be able to fit into one of these exceptions. And I'm getting a little bit of feedback. I don't know if others are hearing that too. But whoever, Katie and Margie, you may want to mute and pop back and forth. I don't know. We'll have to see if you can mute and unmute. So the Stark waiver was effective on March 1st. So this is an example of a backdated thing, all right? So this is a slide mostly to see if you can say this 6 times fast. So there are 6 Stark permissible purposes. And what's really weird, there are 18 blanket waivers under the 6 permissible purposes. And I don't even know that I can explain this in a way that makes perfect sense. But so this sort of sets the table of reasons that you can use one of the blanket waivers. So first, if it's something related to the diagnosis or treatment of COVID, even if there isn't a confirmed diagnosis, that's a permissible purpose. And I think what they're getting at there is the acknowledgement that the testing is crummy. So you can secure the services of physicians and other professionals to provide medically necessary care, including stuff that's unrelated to COVID-19. So what's a real-world example of that? You've got a bunch of doctors who are busy treating COVID folks, and so you don't have anyone to staff your geriatric clinic, right? You may need to bring in additional people to do that work. Well, if you need to pay them perhaps more or do something that's going to be compensation related to draw someone in to do your orthopedic surgeries while this is happening, there's a Stark exception that might protect you. You can ensure the ability of healthcare providers to meet the need. I'm having a hard time distinguishing between really the second, third, and the fourth bullets to me all kind of seem the same, expanding the capacity of healthcare providers. There's an asterisk next to providers because I'm not sure that they use the term in the way we like to use the term. We try to use the term providers to refer to places. A hospital is a provider, a skilled nursing facility is a provider. Things that are reimbursed under Part A is how we try to use that term. They, I think here, might be using it in the medical professional sense. Medicare usually would use the term supplier there. That's kind of, I would usually call them healthcare professionals or something like that. I think that's what they mean here. It was a little tough to tell. And so you can, if you're trying to put diagnosis and care into an alternative setting, you need to get it out of the hospital. You know, you're trying to set your COVID patients out someplace, whether it be in a tent or whether it's, you're trying to get, you know, non-COVID people someplace else. Stark will be somewhat flexible there. And then business interruption. So you've got a medical group that's going belly up, and you're the hospital, and you want to subsidize it, and you're going, we can't because of Stark? Well, I think you can, actually, now. That's going to be permissible. So here are the 18 blanket waivers, and I'm not going to talk about them in gory detail because I don't want to lull everyone to sleep. But the basic, and you'll notice there aren't 18 bullets. We're going to have, I think, 2 or 3 slides with maybe 9 bullets, because they kind of clump. So if you have fair market compensation to a doctor that is either above or below fair market value, normally either of those is a problem. You can't pay too much or you can't pay too little. It's the Goldilocks paradox. Well, there's a waiver for that. Notice the difference between the first bullet and the second bullet here. So fair market value comp to a doctor can be either above or below market, but rental charges, there isn't protection for above market rental charges, only below. And I'm assuming that that wasn't an accident. So the Stark will not allow, the Stark waiver won't let you overpay for a rental charge. It'll only allow you to underpay. There are exceptions for the excessive medical staff. If there's typically a small cap on incidental medical staff benefits and non-monetary comp, that's waived now if it's COVID related. You can do loans. So if one, kind of similarly, medical group is struggling to make ends meet, you can lend them money. There's a limit in Stark. You can't expand a physician-owned hospital. That is temporarily, so basically the moratorium has a moratorium. You can do it now for a while. The same building requirement, which can often limit where you do services under Stark, you have to do them either in a centralized location that's used by you 24 hours a day, 7 days a week, or where you can meet one of the really complicated same building tests. Those are out the window. You can do stuff wherever. There has a limit that prevents ownership in a rural area if one of the family members owns something. People often forget this one, and it's a giant problem for spouses or siblings in rural areas. Technically, it's a Stark problem for one physician to refer something to the practice of his or her spouse if they're in a different practice in a rural area. It's a little wacky. I haven't heard a lot of enforcement on it. It's kind of crazy, but it's there. Now it's gone. And they're going to give you a pass if you're missing writing or signatures or that kind of stuff. So it isn't a complete elimination of Stark, but it's a dramatic reduction in the sorts of things we're dealing with. So EMTALA, the Emergency Medical Treatment and Labor Act. There haven't been a ton of changes since our last webinar, so you can listen to that for a little more, but we'll kind of cover the gist of it here. The government has given us flexibility for transferring people, but not discharging them. That's sort of the overview of how to look at it. So they've relaxed standards on where and when you need to do a screening, but there are still limits. So you can take a patient who's in the emergency department and you can send them to another location, either on campus or off campus, if your COVID screening is outside of the ED. So if you've got a parking lot screening set up and a person walks into the ED, it's okay to send them out, whether that is an on-campus or off-campus location. But, and this is an interesting but, clinical staff should be sending people from the emergency department. You can't bring in me to send someone away from the ED to say you're looking for a COVID test, go out there, because a person's supposed to be screened first. By contrast, if you've got a big hospital campus and you've got the information booth at the side, that person in the information booth can direct someone to the COVID testing if it's not at the emergency department. So there's a distinction between someone who's shown up in the ED and someone who's shown up someplace else in the building. If you have off-site testing that isn't under hospital control, that isn't subject to EMTALA, even if you've got the location staffed with a bunch of hospital people. It's kind of who's running it is the decider there, to quote former President Bush. Katie, I don't know if you want to chime in at all on EMTALA, and then you'll take over with telehealth. And Katie, you're muted.
Oh, thank you, David. I was shooing a small child out of my office. So
you should have brought the small child. You know, the small child could probably add some insight to this.
It's probably true. Okay, so telehealth has obviously been a big topic and has been the topic of previous rule waivers and guidance. And so we want to kind of level set with where we were with telehealth pre-COVID, because that's going to help us understand and peel away the layers of the onion, so to speak, that CMS has done with their subsequent guidance and with the interim final rule. So it's important to remember that telehealth is a defined term for Medicare purposes, and it's different than the communication technology-based services, remote patient monitoring, and those other sorts of terms. And so for Medicare purposes, pre-COVID, the statute describes telehealth as treatment that's done with audiovisual interactive real-time telecommunication technology. And so what's going to be important to remember throughout here and going forward is that the audiovisual part is central to Medicare telehealth. They've said smartphones are covered as part of this, but the dumb phone, the audio-only phone, is not. So we start out with Medicare telehealth being audiovisual interactive real-time. The telehealth is only permitted for a discrete set of codes, and that's been the subject of rulemaking over the past few years. But the list has been traditionally pretty short. We're going to see how Medicare has expanded that list here about the interim final rule in a minute. Pre-COVID, telehealth could only be done when the patient was sitting in a limited number of locations. So it was just in rural areas. It wasn't available for home-based services where the patient was sitting at home. That's changed a bit, which we'll talk about. The telehealth statute also says only certain types of practitioners can provide it, and that's going to be important from the therapy perspective, which we'll talk about. And then pre-COVID, there was a payment to the originating site, which is the place that is where the patient is sitting, typically like a rural hospital. So there's a payment to that site for the expenses incurred in setting up telehealth for someone to receive telehealth. And then there's a professional fee that's provided to the distance site practitioner. And that's separate from the originating site fee. And the place of service code for any sort of telehealth service, there's a specific place of service code 02 so that CMS knew when the service was being provided via telehealth. So, can I advance the slide, David, or do you have to?
I had in theory given it to you, but since it's there, I will just advance it for you. And we'll
All right,
keep it
thank
easy.
you. So as I mentioned before, I'm trying to advance my space bar, but it's not working. So bear with us, everyone. So as I said before, the still current position, even despite the first round of waivers and guidance, and now the most recent round of waivers and guidance and the interim final rule, CMS's current position is still that telehealth has to be done with technology that has audio-visual capabilities. So it can't be, and it has to be real time. It can't be the dumb phone, the rotary dial, the party line phone. That's a telephone, and telephones can be used for other things that David will talk more about, but not for things that are considered, quote, telehealth. So the first round, oh, I think I advanced the slides on my own, so maybe not. Maybe we're just synced up, David. The first round of telehealth expansion was, the weeks are blurring together, but a couple weeks ago, where CMS said, as of March 6th, and this is still in effect, we're basically going to get rid of the location requirements for telehealth. We understand that people are sitting in places and they need to stay there because of the risk of infection. So you can now be in your home and receive telehealth as a patient. Medicare will pay for it. You don't have to be sitting in a rural area. They've blown away the location requirements. So now coming to the current, I guess, the expansion from Monday's rule. So the interim final rule, this is where CMS is being very, I think, charitable and recognizing for once the realities of practitioners from a resource perspective who are providing telehealth and having to switch really quickly to this new platform. So as I said, pre-COVID, the practitioners would have billed the distance site service, and then the originating site would have gotten paid for the facility fee. Now, CMS is saying, look, if you're providing telehealth in a situation where you normally would have been furnishing that service in person, we don't want you to use the telehealth place of service code anymore. We want you to use the place of service code that reflects what would have been the case had COVID not been here. So if the patient would have been in the office and the only reason you're providing telehealth is because of COVID-19, you should list place of service office. And that's going to do a couple things. That's going to allow then CMS to pay the practitioner for the cost of the service that would typically have been incurred by the originating site, but are now being incurred by the telehealth provider because that originating site is very likely the patient's home. So that facility fee used to be paying for costs that a local rural hospital would have had to set up to get people in for telehealth. Because CMS is recognizing that practitioners are providing telehealth and probably needing to keep on staff and do various sort of incur various expenses to provide that telehealth, they're saying if you use the place of service code that you would have used if the person had been in person, we can now pay you for those costs. So they're going to allow you to get paid for those costs in this crisis. The other really great thing about telehealth that's happened as of the March 30th final rule is that, now this is a situation where it's a March 30th rule, but for the dates of service that you can use this for are going back to March 1st. So what they've done is made that fairly narrow short list of telehealth codes much broader and much longer. And so for dates of service beginning on March 1st, 2020, and through the end of the PHE, there are going to be a bunch more services that can now be provided via telehealth. And remember, telehealth still requires that real-time audio-visual communication technology and not the dumb phone. But the types of services that they're expanding are really pretty broad. So we're seeing telehealth now being allowed for ED, initial hospital visits, initial nursing home facility visits, critical care, custodial care, home visits, and I'm not going to go through every one, obviously, but we've listed all of the expanded new telehealth codes on our slides here. So this is really a nice kudos to CMS. Now, there is I say that, and now I say there's a little bit of a catch, and that's with respect to therapy. So CMS has added therapy codes to the list of telehealth, which I'll show you in a minute. However, this is a WTF moment for the community because the statute for telehealth, as I said before, lists the types of practitioners that can provide telehealth. The statute does not include physical therapists, occupational therapists, or speech language pathologists as statutorily authorized individuals who can provide telehealth. So technically, and CMS is correct in saying they can't waive this requirement and allow during this emergency PTs, OTs, and SLPs to provide telehealth because it's the statute that makes them unable to do so. So,
I'm going to chime in. I'm chiming in for a second here, Katie, to say, because longtime listeners of us know that have heard us talk about the anti-markup rule, and CMS says that the anti-markup rule applies to the professional component of a diagnostic test. And statutorily, that's just not true, because the statute applies to diagnostic tests, and the interpretation is a professional component. And so it's crystal clear that it does not apply statutorily to the professional component. And when we commented on that, when the rule came out, CMS's response was, well, it is true that the statute doesn't do it, but we believe Congress intended to do it, and so we're doing it anyway. So they are applying the anti-markup rule in a way that the law doesn't allow, and against people. And they were willing to basically use a divining rod or Karnak the Great to figure out Congress's intent. And here, where I think it's quite clear, Congress did not intend to say therapy can be done, but not by physical therapists, occupational therapists, or speech language pathologists. They chose not to do the same thing they did with the anti-markup rule. And that's one where I'm going to call, hey, CMS, come on. If you did it on the other one where you really shouldn't have, here in the emergency, you can divine congressional intent. So that's my soapbox moment for the webinar.
All right, so, oops, how do I go back? Thank you, whoever put me back. So now there are codes on telehealth that can be used for PT, OT, SLP, but the folks that can provide those services and get paid for them, you can always provide them and not get paid, but the people who can provide them and get paid for the telehealth services are listed on this slide. So Godspeed to those who are trying to make this work. And this is the list of services that can be provided. The other thing that they're doing with telehealth is CMS is basically saying that there are some services out there that have frequency limitations. You can't bill them so many in a certain period. The services here, the inpatient visits, the subsequent nursing facility visits, and the critical care consults, they're removing any sort of frequency limitation for those services, again, back to the date of service, March 1st, 2020. All right, now David's going to talk about when you can use it on the phone.
Okay, so there are, I guess, to be grammatically correct, a couple of codes that are E&M telephone services. So they are 98966 through 68, which are for non-physicians, and you can see the professionals on the screen just for the acronym. It's so licensed clinical social workers, and then I think people know PTs, OTs, and occupational therapists and speech language pathologists. The therapy uses and I should have looked these up better, and it's because they're ripe for jokes, the Go GP and the Good Night modifier. And I do not actually know what those are, so I'm embarrassed. I meant to look at that this morning and then forgot. So you can scorn me in the comments for this. Then there are E&M codes for physicians that are 99411 to 43. This is a really important point. If you look up those codes in the CPT book, they will say they are for established patients. CMS is saying, we don't care, you can use them for new patients. So having ranted about CMS a couple of minutes ago, they really are working hard on this and trying to be flexible. But a thing to keep in mind is their flexibility this is going to be tough, right? Because if you would listen to one of our typical compliance talks, we'd say, read the CPT code and don't do something that's inconsistent with the description of the code. Well, here you can, right? And that's going to flummox people for a while. All right, the CTBS which is communication technology-based service. So this has been around for a little while, but they're not used a lot. And so there are two codes. The first one is for the remote evaluation of a recorded video or image. So it's like, this is kind of an email-y thing. So I've got a weird looking lump on my skin, and I take a picture of it and I send it to my dermatologist, and the dermatologist writes back and says, it's a mole, chill out. And then a GO212 for a quick phone call. And so those have been covered for a while, but I don't know what they pay. I don't think it's a ton. There are two big limits on them, or maybe it's one big limit. You can't be 7 days following an E&M service if this act is related to the original E&M thing and it's within 7 days it bundles, or if it causes either a visit or a procedure to occur either within 24 hours, or it causes the doctor to say, I will do it at the soonest available appointment, then you're supposed to view the email or phone call as bundled with the original or with the procedure or E&M, and you can't bill it. I put an asterisk next to related because what the heck is related here? And I don't know the answer. So I'm going to use a real-world example from one of our clients who asked, all right, person's in the hospital. They get out. Normally, we would do a, God, I'm blanking on the term I want to use here. I needed to have gotten more sleep last night. Not a wellness visit, but a care management visit. They would normally have had a care management visit, but they can't come in for that. So we're going to do a phone call, right? Is that related? And so first off, how, should it be, so you could do an E&M visit, right? That would be okay. But this 80-year-old person has a dumb phone and they don't know how to use they don't have a smartphone. So backing up for a second, I don't think Katie talked about this at some length. We've talked a little bit about if you just use the audio feature on a smartphone, is that good enough? And I think the answer to that is yes. We think that if it can do audio visual and you just use audio, we think that that is okay in the wording of the stuff. It is not crystal clear, although it also highlights the arbitrariness of saying that it has to be a smartphone, right? But so you got an 80-year-old who doesn't have the smartphone, so can you use this code? And is that call related to the hospital discharge? I don't know. I think I would argue that it is not, in the sense that if we think that there is another code that would normally have been billable and we're substituting this, I think in the gestalt of what CMS is trying to do, which is to make sure, A, you don't have to go in the room with someone, and B, you get paid for your work, I'd go with it, is my answer. I can't promise you it's okay. If you read the full preamble, and I don't think we put a link, or I put a link, I'll take the fall on this one, to the actual interim rule, and it isn't formally published yet. But if you read through it, they're working hard to make sure that medical professionals and patients do not have to be in a room together unless it's absolutely necessary for the safety of both the medical professional and the patient. Now, you do need to get consent, and so it talks about how consent can be documented by an auxiliary personnel, and that can be done under general supervision as if that was a concern, but you do have to come up with a way to document the consent. Now, this is a big and surprising and good thing. Let's say you do a telehealth, so that's smartphone, E&M service. CMS is changing the way you code for that. And this, if you listened to me on Monitor Monday this Monday, I gave, it wasn't a wrong answer, it was a then correct answer, which has since been rendered moot or changed. Now, CMS is saying you can choose your code based on either the medical decision making or time. So basically, they're going to what will be the principles come 1/1/2021 when they change the E&M coding. They're accelerating that for telehealth. And right now, I think there aren't a lot of visits happening in the office, so for most encounters, you can use medical decision-making or time, and generally in the past, time only counts if half of the visit is counseling and coordinating care. No longer true. Now, you can use time even if no counseling occurs. And for reimbursement purposes, the history and exam are irrelevant, and there is no need to document them. Obviously, from a medical malpractice standpoint, any history or exams that are done should be documented, but for billing, we do not give a rip about them. And I think this is great, but I do have one challenge for CMS. If we're doing this and we're saying the exam doesn't matter, why isn't a dumb phone good enough? It should be, because we can do medical decision-making in time off of that. I'm hoping they'll get there. To be clear, they haven't done it yet. All right, copays and deductibles. The OIG is now allowing a waiver of all cost sharing for any telehealth. And I think there are a couple of things going on here. I think people are worried about the economics. Also, it's kind of a pain, right? I mean, how are we supposed to collect? Are they going to write a check? You could do credit cards over the phone and things like that, but it just would be a logistical challenge. The OIG has said blanketly, we don't care if you collect the copay for a telehealth service during this emergency. We will not deal with it. It's not going to be a problem under either the anti-kickback statute or the civil monetary penalty provision. So that is wonderful. But remember, if you choose to do that, you're in essence taking a 20% haircut. You can collect the copay and deductible. This isn't preventing you from doing so. You are not required to. Now, what are private plans doing? They're all over the place. And this morning, you've got people, I think we have people from literally all 50 states today. So I try to not be parochial and talk about Minnesota, but I'm going to be parochial for a moment. I woke up to a newspaper story that in Minnesota, the governor has met with the insurers and they have agreed that there will not be copays or deductibles for COVID treatment. Now, ignoring for the moment the logistics of, well, what is COVID treatment if you don't have confirmed cases of COVID treatment, I'm going to ignore that big question and ask a different one, which is the announcement does not state whether that means the insurer is going to reimburse healthcare organizations for those copays and deductibles, or whether they have graciously agreed that healthcare entities are not going to get to collect copays and waivers. I don't know what the state has done on that deal. I will find out soon for Minnesota, but that same question is popping up all across the country, right? Plans are saying, oh, no copay and deductible, but you have to figure out if that means they're paying it or if that means you've just given a discount that someone has agreed you are going to give. We're not going to talk too much about the CARES stuff. Katie will talk a little bit about a home health provision, but there is, and the reason we're not talking about it is it's more economic, as we said, but there is something in there that says you have to list the COVID test cash price on your website if you do COVID testing. And then an insurer either will pay you whatever they agreed to in their contract with you. And so if you have a contract with an insurer that lets them set the price for new services, they could just do that, right? But if you don't have a contract with them, or if the contract doesn't let them just unilaterally set prices, an insurer is required to pay you the list price you have on your website. And part of what I want to flag about this is I wonder if there's a sign going forward as to the pricing stuff. And if you think about the price transparency rule, which has not yet been kicked down the road, I do have to wonder if, I don't know what's going to happen with that with the emergency, but I sense a theme here, which is there's going to be much more pressure to publicly disclose prices. All right, one of the other big legal changes is that we are now going to allow direct supervision to occur remotely. So right now, direct supervision is defined in 410.32 of 42 CFR. So that's the diagnostic test rule, and that's where they define general, personal, and direct supervision. And just so general is basically you are somewhere on the planet, no geographic requirement, you're generally responsible. Direct is you're in the office suite, personal means you're in the room, okay? So they have added a sentence that says, during a public health emergency, the presence of the physician includes the virtual presence through audiovisual real-time communication, so that's smartphone, not dumb again, when the use of such technology is indicated to reduce the exposure risks for the beneficiary or healthcare provider. So the big question I had the first time I read this is, does that mean the link has to be open? Or is it enough that if you've got your smartphone in the pocket, you know, if Dr. Jones, she's got her smartphone in her pocket, is that enough for her to provide the supervision? Well, let's look at what the way direct supervision is defined. it says that you have to be present in the office suite and immediately available to furnish assistance. And that bold and underlining obviously doesn't appear in the rule. I interpret that to mean you have to be able to duplicate that remotely, and so availability should be enough. It's a little ambiguous in the writing, but otherwise it wouldn't make any sense. It would suggest that the off-site doctor has to stay on one-to-one with the person the whole time, and that would be a higher level of supervision than we had before the emergency, and they cannot have meant that. I forgot another question that I should have addressed back when I was talking about telephone visits, another real-world question. GI Group says, hey, we're doing all kinds of hospital consults right now. We go into the hospital. We don't go into the patient's room if they've. We're reviewing the record out in the hallway, and making our decisions based on the record and talking to people. How should we bill those? So now, first, a great thing if you can get a smart device in the hands of the patient and just say a quick hi on that. Problem solved. It's now a telehealth visit, and you're good. Next best option, if you can look at the patient through a window, under the longstanding medical principle, you've got a face-to-face visit and you should be good. If you're purely working off of the paper, the system isn't that kind to you right now, and it's not clear how you do that. I think you'd probably go with an E&M visit, and you would document why you off of kind of view it as a telehealth encounter. And go off of time and medical decision making. But if you don't in fact get the telehealth part there, we're playing a little fast and loose with the rules. All right, Katie, you're going to talk about home health, I think, including one of the implications of the CARES Act.
I am. I'm actually going to go. We're getting a bunch of questions on a modifier question for telehealth. So I'm going to go ahead and try to head those off,
Okay.
or answer them rather. So we had talked about how CMS, so this is hard because the interim final rule talks about the modifier, but as far as I can tell, the guidance from CMS about the interim final rule doesn't talk about a modifier. So the interim final rule says that when you are billing for a telehealth service and it would otherwise have been an in-person service, CMS is allowing that practitioner to bill for the service as if with the place of service as if it would have been in person. So it could be in the clinic. If it's telehealth, but it would have been in the clinic, you bill place of service clinic. It's also saying if you're going to do that, we want you to use this modifier 95 because that will help to describe to us what services are being furnished via telehealth, even though you're not using the telehealth place of service code 02. Now, if for some reason you still want to use the telehealth place of service because maybe you're going to try to capture the facility payment rate for the originating site, then you can still use the place of service 02, and that's fine too. So I think it's a choice, and I don't think CMS is going to be super picky about what you decide here. All right, that may have made it more confusing, but I'm hoping it helped a little bit. Okay, so let's talk a little bit about home health and what sort of relief we've gotten from the interim final rule and the CARES Act. So one section of the final rule talks about the ability of home health agencies to use more technology. I thought this was sort of confusing because, I don't know, just the way it was written, it didn't really tell me very clearly how it was helping anything, but I think I'm getting there. So basically, you can't sub out technology for an you can't sub out an in-person visit for technology. That's still really clear. But I think what CMS is saying in this interim final rule is that we recognize that because of this COVID-19 issue, it may be appropriate to amend plans of care to incorporate more technology communications to maybe decrease the number of in-person visits and increase the number of technology communication visits, whether that be telehealth or remote patient monitoring, in order to deal with the realities of this crisis. So basically what the final rule says is that you can amend the plan of care to incorporate different types of technologies and change the frequency or types of in-person visits in the plan of care, so long as you are explaining why in the plan of care the use of the telehealth or the remote patient monitoring might be more appropriate given the circumstances. And so backing up to, I think, 2019, CMS allowed home health agencies to include the costs of remote patient monitoring in their cost report as an administrative cost. They are now broadening that to say the cost of other types of telecommunications technology that are used for your business can also be included on the cost report for purposes during COVID-19. So they gave an example of this, a patient of increasing use of technology. A patient recently discharged from the hospital after bypass surgery typically would get home health nursing visits, let's say 3 times a week for medication management, et cetera, teaching, assessment. And then the patient develops a fever, cough, sore throat, and has a confirmed COVID diagnosis. And the doctor thinks they can manage this at home. The plan of care, in this case, may be updated to include 1 in-person skilled nursing visit per week to assess the patient, but then do a video consult twice a week because because that makes more sense in terms of infection control, and you can manage the symptoms remotely. So that's an example they're using. If you're in the weeds on this, I would suggest reading the section of the final rule. Oops, now I'm back to not the slide I meant to be on.
All right, I'll be able to fix that. Hang on.
Okay.
We're looking at the storm chasing stuff. So let's see. Hang on.
We're in the middle of a storm, right?
Yeah. Well, let's see. Okay, so we're gonna. Don't mind us. There we go.
Yeah, I can start talking about the next one. Yeah. Okay. So the CARES Act was also very helpful with respect to home health in that it now authorizes nurse practitioners and PAs, physician assistants, to order home health, do the certification, do the recertification, assuming that's in their state law scope of practice. So now it's no longer just a physician who can do those functions. Their NPs and PAs can now do that as well. All right. The next bit about home health is this clarification of, it's not an expansion, I would say, of homebound status, but it's a clarification that says, basically, if someone, not just the physician, but maybe the PA or the NP who's determining homebound status for purposes of home health services, if someone has been determined, if it's been determined that it's medically contraindicated for someone to leave their home because of a confirmed or suspected case of COVID, or some underlying condition that may necessitate them to stay home in order to avoid contracting COVID, that is one example of who may be homebound during the public health emergency. Now notice that take note, that doesn't mean that's the only basis for home health care, but the person would also need to meet all of the other requirements for home health eligibility. But that's a clarification that COVID implications could justify a homebound status determination. For hospice, this one's really quick, but hopefully helpful. Pre-COVID, hospice face-to-face encounter was necessary to certify initial hospice care and recertify hospice care. During the public health emergency, you still need the face-to-face encounter for the certification. However, for recertification, CMS is saying that's really just sort of administrative. We're okay saying that you don't need to be face-to-face. You can use telehealth to accomplish a recertification. All right, and then inpatient rehab facilities, we've seen a little relief as well. During the public health emergency, CMS says, so typically there would be a requirement that within 24 hours of admission, the physician must evaluate the person in the inpatient rehab facility. CMS is removing that 24-hour post-admission evaluation requirement during the emergency. They're also saying that the previously required 3 face-to-face physician visits during the week, now during the emergency can be furnished via telehealth. And then I've always thought this rule was sort of strange. There's a rule for IRFs that says, basically describes how intensive services need to be in order for someone to be needing the IRF services. And it has, in the actual regulation, it has stated the current industry standard expectation for intensity is that someone in an IRF would need 3 hours of therapy per day for 7 consecutive days. During this emergency, CMS is saying, look, if your IRF or your program is impacted by COVID-19, and not just the patients in the program, but kind of your environment with staffing disruptions, et cetera. If you're impacted by that, they're going to look past that current industry standard expectation and not necessarily enforce it. So the intensity of service is not going to be an audit risk during this emergency.
I'm just going to chime in for a second because Katie, you and I have dealt with this one a bunch of times, but it's always good to just remind people that that 3-hour thing, it isn't that you actually have to get, it's kind of the expectation that they can tolerate 3 hours. And so just remember, if someone comes in at 2 hours and 57 minutes, that doesn't render the service not billable. Sometimes auditors come down that way, but they're wrong. All right, we're now going to move to a section. We're getting near the top of the hour, so we will go over 1 o'clock. Remember, if you have to go, you go, and you can always watch this later. We have a boatload of questions. We will try to answer a bunch of those. We're not going to get to them all. Sometimes we say we will answer questions afterwards. I have the feeling based on the volume, we can't make that promise, but we'll see what we can do. But we're now moving to the part where things are generally going to go quicker up until Margie's explanation of the Small Business Association stuff. So there's a new thing allowing clinical labs to collect from homebound people, including non-hospital inpatients, a term that I had never heard before, and SNFs, and so that's just there, so that it basically lets labs, it's recognizing that we don't necessarily want people coming into the lab. We may send a lab person to the home, and that labs should get paid for that. The teaching physician rules, there have been a lot of requests about change to that. There has been a change, although I don't think people are going to love this change. And I suspect this may be one of the most poorly understood changes. I think people are going to misinterpret it. So the regulation, which is 4415-172, says that if a resident participates in a service furnished in a teaching setting, physician fee schedule payment is made if a teaching physician is present during the key portion of the service using an interactive telecommunication technology for any service or procedure for which payment is sought. So it's interesting because the wording here is really similar to the wording for the incident 2, but I come down very differently on this compared to there. So for incident 2, I think the availability by phone is sufficient. You don't need to be there. For teaching physician, I don't think you can just have the supervising doctor with the phone in his or her pocket. I think the phone has to be on. And I'll be interested to see if CMS thinks I'm wrong on this, but the way they worded it is because this is the long-standing rule is that the teaching physician has to be present during the key portion. And if you look at what it is, they have to be present via telehealth. I don't think that's available. I think that's you got to be there. So I think that they're setting this up for a situation where if the supervising physician has got COVID, he or she can be sitting, or if they're quarantined, because they can be sitting in their home and they can sit in on telehealth with the resident while the resident sees the patient. But this is not something that's going to let the resident and the teaching physician run parallel rooms. I did not set up a slide to, I should have, so my apologies. There has been a long-standing low-level E&M exception. It's often called the family practice exception that allows people, residents to do levels 1, 2, and 3. They have expanded that to allow 4s and 5s. So that is expanded, but you aren't going to be able to otherwise use residents willy-nilly without the physician being present. They won't be president. I so was going to make a comment there. I will sit quietly. So there are a couple of other things. Historically, moonlighting residents can't get reimbursed if they do anything for a hospital inpatient. That they're relaxing. So if say an anesthesia resident went to intubate an inpatient, that normally wasn't billable. Because they couldn't moonlight for inpatients, that they now can. And for those of you who get teaching physician payments, time generally outside the hospital, if it was in a resident's home, and when I say resident there, I mean the person training to be a doctor, or in a patient's home, that normally wouldn't count toward the residency program. It can now. Katie, walk us through some opioids.
Okay, so for opioid treatment programs, CMS has said it's really important for people to be able to continue to do the therapy and counseling portions of their weekly, the weekly bundle of services that OTP provides, and then any additional counseling and therapy. So very specifically in the final rule, CMS said that those services can be furnished by dumb phones or audio-only telephones. So you're seeing some leeway here. Maybe we'll see more for other types of services in the future, but this is the one place, or one of few places where CMS is saying you can use the dumb phone to continue to get paid.
All right. I don't know what happened there, Katie. We'll just, if that's
I don't know.
Or yours. Let's assume it's me. It might be me. I'm trying to answer questions, so it might be my fault. All right. Did I get us to the right slide? Yes. Okay.
Yeah.
I did get us to the right slide, and then I lost it up. So there are some changes to NCDs, national coverage decisions, and local coverage decisions. So first, face-to-face requirements that appear in them are waived unless they're statutorily required. And they only used one example, which was power mobility devices. There might be others. I don't know which ones are statutorily required without looking. They didn't explain more about that, but most face-to-face are gone. The chief medical, if there is an NCD or an LCD that authorizes, that says only a doctor can do something, or if it uses the term physician, the CMO, the chief medical officer in an organization, can permit other non-physicians to do it. Now, one of the things that's a little crazy to me, and Katie, you and I did not talk about this, but so I'll see if you have the same thought. LCDs are generally not binding. Like we talked about this at length in our Avoiding Unnecessary Refunds webinar. An LCD is way down in the pecking order. It is, NCDs totally binding. They're basically a regulation. LCDs are not, and so I was really surprised to see them equate the two here, because I would generally say you can blow off an LCD, and to back that up, I would say the AceraCare case, which was an 11th Circuit case, which has a great sentence in there about how LCDs are kind of advisory. This proposed rule sort of equates the two, and that bothers me. Then there are waivers of a bunch of respiratory-related NCDs and LCDs, and then also the clinical indications are waived on the following ones. I'm not going to read them. They're in the handouts. You can just see what they are. All of the clinical indications of those are sort of being put into suspense. Katie, you want to talk
briefly,
about?
Yeah, I'll talk very briefly about this. Basically, CMS said in the interim final rule, we know that those people who are in alternative payment models for the quality payment program may be, I'm editorializing, freaking out about meeting various measures because of COVID-19. We get that. We may be doing additional rulemaking to either amend those requirements or just suspend the APM policies as needed. So CMS hears you, and stay tuned for more. All
right, hospital services under arrangements. So under arrangements is a super confusing term, but it's basically the idea that a hospital can subcontract to have someone else provide a service, all right? And routine services were supposed to not be, you were not supposed to do routine services under arrangements. And there's a fairly lengthy discussion about concern that maybe you've got a critical access hospital that's got a patient that needs ICU treatment. And so the critical access hospital sends the patient to a PPS hospital, perhaps in the same family, but does it under arrangements such that they're putting the costs on the critical access hospital's cost report and still calling it their patient, even though the person is in the PPS hospital. And the alternative would be to transfer the person to the PPS hospital, and that might have lower reimbursement. And CMS generally is worried about that, but they are saying right now they're not going to focus on that. They're going to allow routine services to be provided under arrangements, but that, you know, going forward, that's going to be a problem.
All right, really quickly, the another supervision requirement that's relaxed is for those services that are on the list that are called non-surgical extended duration therapeutic services. Typically, for hospitals to provide those types of outpatient services, you need to have direct supervision, I believe, at the initiation and maybe the end of the procedure. But now CMS is saying during public health emergency, you can have general supervision throughout the entire time, including the initiation and the end of it, I think they're hoping to relieve physician and other practitioner burden and being more available for other things.
I'm glad you knew NSEDT because I have literally never seen that before in my life. All right, advanced payments to suppliers. This is something that got a lot of play, and I kind of shrugged my shoulders. I think this is a so what. So that you have the ability to apply for accelerated payment of basically your Medicare receivables. In the old, that's been around for a long time. It's not used much. Now you can get 100%. It used to be 80%. You start to have to repay after 120 days, and you know, most hospitals get a year. Most other folks get 210 days after that to repay. The thing that to me is not that big a deal about this is it doesn't get you any more money. It just basically you can draw down your Medicare AR. And I don't think that's generally going to be a thing that saves you because this problem is likely to last long enough that you're going to draw down. It kicks the can down the road a bit, but it's money you were going to get just a little bit down the road. So I'm not that excited about it. So now Katie can talk ambulances.
All right, so quickly, the ambulance origin and destination requirements have been relaxed during the public health emergency. Previously, an ambulance was supposed to take people for a medically necessary ambulance ride or transport to either a hospital or a critical access hospital or a SNF. The destination requirements have been relaxed in that basically if the ambulance needs to take the person to an alternative site, maybe perhaps to be tested for COVID, if that's part of the local protocols for ambulance transport, that's okay. The destination doesn't have to be those three institutions. It can be whatever site is necessary to treat the condition of the patient as determined by your community.
Appeals, so they made some changes to appeals, but this is another one where the play is getting more than it should. CMS is going to permit MACs and QUICs to grant extensions, but the MACs and QUICs don't have to. So hopefully they will be reasonable, but CMS didn't tell them they must. It told them they may. And so there's a bunch of flexibility that can exist, but the bottom line is don't assume anything has changed. If you want an extension, you have to ask for it. It's not granted automatically. And in theory, the MAC or QUIC can tell you to pound sand. I noticed this is like the A section of our talk. Then here are just a few waivers that we didn't cover in too much detail. Some of them because I didn't understand the significance. So like the ability to lease auxiliary personnel and you can bill them incident to, there's a waiver that grants that, but I always thought you could. Hospital services can be under the care of a nurse practitioner or physician assistant if the state's emergency preparedness or pandemic plan allows that. So you no longer have to have a doctor overseeing all of the care. So that is actually a real flexibility. There's some MIPS exceptions, including waivers of deadlines, and they're going to create a new possible MIPS reporting thing if you do clinical testing of COVID treatments. Katie, I think you're going to do this one.
Yeah, so this is important in that for Medicare and Medicaid, if the rule requires that a state license, that the person be licensed in the state in order to get paid for the service, that's been waived. So the state rules may still require you to be licensed to provide it, but Medicare and Medicaid are going to say, we'll pay even if you're not licensed in the state. So that's nice. You can't be excluded though. Typically, opted-out physicians have to stay out for the 2-year period. They may now re-enroll sooner than that. Thankfully, CMS is suspending all revalidation efforts, which have been sort of very much underway recently. So those are being suspended. And then they're also waiving any signature and proof of delivery requirements for Part B drugs and DMEPOS. If you have documentation that shows you couldn't get those or wasn't practicable due to COVID-19.
All right, so now we are going to turn this over to our colleague, Marguerite Ahmann, who's going to walk us through CJR and then the small business stuff. And then after that, we will try to work our way through some of the questions. And remember, if you have to sign off, you can always listen to this anytime on demand on the website. It's likely it should be up by Monday, I would think, most likely. Margie, take it away.
Thanks, David. So in the interim final rule that David and Katie have been referencing, there were just a couple of changes to the CJR program. The first is that, so CMS had put out a proposed rule extending the CJR program back at the end of February, which now feels like eons ago. And so the interim final rule extends the 5th performance year of CJR by 3 months. And they're doing that to try to ensure continuity of the model during this public health emergency. So it'll now run through March 31st of 2021. The second and probably more impactful change is that they recognize that their current extreme and uncontrollable circumstances policy was too narrowly drafted. It was drafted back in 2018 and contemplated the wildfires and hurricane type disasters, but didn't really contemplate a pandemic of this sort. So they've broadened that policy. It'll apply to all hospital participants during the time of the emergency, and it places some financial safeguards to protect hospitals from the rising costs associated with episodes due to COVID-19. So essentially, it'll be a cap on the costs that are allocated as part of the episode, and it'll be capped at the target price. So now, I'm going to ask David to move the slide since it doesn't work on my screen, and we'll move on to the payroll protection program. So there are various sources of funding available and contemplated by the CARES Act. We're just going to talk about one, which is particularly pertinent today as applications are being accepted today and seems to be the most talked about right now. But there are others. There are other SBA loans. There will be grants coming from HHS. There are contemplated loans for mid-sized businesses as well. So if this doesn't fit your needs, it's not that there aren't resources out there for you. But the payroll protection program is the SBA, Small Business Administration's forgivable small business loan designed to help businesses with a short-term loan to cover payroll and other necessary expenses to essentially keep the lights on. These are available for businesses with 500 or fewer employees. There's an asterisk there on the slide because there are a few different industries, none of them healthcare related, where you can have more than 500 employees if you meet a different industry employee-based size standard. There are also some affiliation rules that you should be aware of. So if you and another entity share joint ownership or joint management, it's possible that those affiliation rules will make it so that you have to aggregate your employees, so just be aware of that. But assuming that you are eligible, then you want to look at the maximum loan amount that you can take out under this program. And that is going to be based on your historical payroll costs, which we'll get to in a couple slides. But essentially, you're going to want to look at your prior 12-month period, come up with an average payroll amount each month, and then multiply that by 2.5, and that'll be the total loan amount. It cannot exceed $10 million. But you do have the option if you have applied for one of the other disaster loans from SBA, you have the option of adding that amount into this loan and having it essentially refinanced under this program. The one big nuance is that all of those payroll calculations that you are doing to come up with your kind of historical amount, as well as when you look towards what you can use the loan proceeds for, you need to cap any compensation at an annualized amount of $100,000 on a per employee basis. So you can use this towards your more high earning employees. You just can only use an amount up to an annualized salary of $100,000. So moving on to the next slide, the general or the loan terms for this program are going to be the same for all borrowers. David, do you mind going on to the next slide? And so we'll talk about forgiveness, but any amount that is not forgiven will have a 2-year maturity and a 1% fixed rate. So it's a really low rate. I will say prior guidance from SBA did say it was going to be a 0.5% rate, but yesterday we got the interim final rule for this program, and 1% is the rate that they settled on. All payments under the loans are deferred for a 6-month period, but interest will accrue during that time. So the permissible uses for these loans include payroll costs, and on the next slide, I'll cover what that means, interest on mortgage obligations, rent, and utilities. In this latest guidance from SBA that we received yesterday, it sounds like they want 75% of your payroll costs or 75% of the proceeds of the loan to be used towards payroll costs categorically. So it used to be framed as just sort of a forgiveness factor. Now they seem to be using that as a broader requirement. So payroll costs, I'm not going to go over this in great detail, but it's just important to note it's not just salaries, it's a lot of other benefits that you can factor in there. Again, you want to make sure that you're capping all of those, the salary amounts up to $100,000 on an annualized basis. And you cannot include any sort of employee compensation if the employee's principal place of residence is outside of the U.S. And then we'll get into the forgiveness aspects. And so the great thing about this program is that the loan is potentially fully forgivable. So they're going to look at the covered period and make sure that during that time frame that you used the loan proceeds towards what you said you were going to. So you, as part of this, have to certify that you need the funds and that you're going to use it towards payroll. And 75% of the loan proceeds need to indeed have been used towards payroll. So they'll look for documentation of that. They also want you to have maintained your FTE count and not to have substantially reduced anybody's salary. So that salary reduction only applies if the reduction is in excess of 25% for any individual employee, and they're only looking at employees who make under $100,000. So if you have a highly compensated physician on your staff, you are able to make larger adjustments to their salaries than your administrative staff who may make less than $100,000. And let's see, so if you do have a reduction in FTE during the covered period, then your loan will be the forgivable amount will be proportionally reduced by that decrease in FTE. So they're looking at this covered period that I just mentioned is the time period between February 15th and June 30th. Now, they acknowledge that many people have had to make very tough decisions during this time period to lay people off or furlough their employees. And so you have until June 30th to restore that FTE count, restore salaries, and as long as you do it by that time period, it won't be counted against you for purposes of forgiveness. I will say, now that we know that 75% of the loan proceeds need to be used towards payroll, you'll probably have to build those numbers back up quickly in order to make sure that you meet those requirements for loan forgiveness. And with that, I will turn it back over to David. Or Kate.
I will try to turn off the mute. So, okay. So first, just I miss our office a little bit, and in particular, I miss this view. And so this is the view out of our office, and with the rainbow, because we're going to get through this. It's going to be dark. The next few weeks, I think, are going to be really dark for a lot of people. But it is good to remember there is another side to this, and we will get there. And someday we will be back in our office, and I will see something like that again, I hope. Okay. So we are going to try to whip through some questions now. Maybe we'll go just for a few minutes here and understand if you need to sign off. On the screen, you can see our smiling faces, and if you don't mind the creepiness factor of it and you want to be our LinkedIn friends, you can scan our little codes and link to us. The pictures of Margie and Katie are pretty accurate. Mine's a little old, so and I do have a Corona beard. Okay, so first on the question, I think one thing that is confusing a lot of people is the site of service or the place of service. And actually, I probably helped this by site of service and place of service are slightly different. So basically, you should view the encounter as pretend there wasn't a COVID emergency. Where would this thing have happened? If it would have happened in the clinic, you're going to use the clinic code and you're going to bill it as an 11, or you're going to use a site of service 11. And if it would have occurred in an outpatient hospital, you're going to be in sort of 22 or 24 land, and you're not going to use O2 even though you're using telehealth. All right. So
you're going to use the modifier, right?
Thanks. Okay. So go ahead, Katie. Talk about that.
Oh, sorry. So if you are using telehealth because of COVID, and you're billing with the place of service that would have happened if there had been no COVID, you use the modifier 95. So you're telling CMS by 95, hey, I'm billing the place of service, even though I'm billing the place of service, the clinic or hospital, even though I'm using telehealth because COVID has forced us to do it this way. That's what they're trying to collect, that information.
Okay, so I see another question here where I was not articulate, and so you do need to get a consent on some of these, but an oral consent is fine. So you can the consents can be obtained by the physician, by a non-physician, and getting it orally and documenting it in the record is enough. The CMS is doing a really good job. That is what, basically they're getting rid of pens, right? You don't need to have people sign stuff in a hand paper over or mail things. And that is, I think there's a broad area. And if there's something that we're not thinking of or that they're not thinking of where it's an interaction where you have to get something in writing from the person, I think you can assume that CMS ultimately is going to get to a point where they're going to say you don't need to do it. They clearly understand that and are working hard on it. Katie, you want to snag a question or two here?
Yeah, I had a question about the CARES Act. Does the CARES Act make so the CARES Act said that PAs and NPs can order and certify the home health plan of care. And the question was, is that just during the emergency or is it permanent? I think it's permanent. So that is a broader change, then.
And I am not sure. I saw that one too, and I was embarrassed. Like, I read that section, and I should totally know, and I don't.
I think it's permanent, but this is why it's difficult. There was also a question about what blanket waivers are real waivers, like which waivers can we just run with instead of asking for a waiver from CMS or telling our state agency or regional office. There is a decent guidance document on this that makes it easier to figure out than just looking up the actual waiver, which lists a bunch of statutory sections. Is there a way for me to post this so everyone can see? If there isn't, I can send you the document if you email me after the webinar.
Let's see. So there are a ton of questions, so I apologize. There are a ton of them, and it is hard to read all of these things. Let's see. Are there requirements for virtually checking the patient in to make sure you have the correct patient? There aren't requirements that you do that. I mean, it's interesting. People often ask for an ID when you show up, and there were the red flag rules and stuff like that. But there isn't like a law that says you need to get a driver's license of someone who shows up. So since there aren't normally, I don't think that there are for this.
What's interesting about that is that I've seen in looking at state laws on telehealth, some states are really particular that you like try to identify the patient. So it may be a state law thing. It's probably mostly a common sense thing.
I'm trying to understand this question real quickly, and I'm not. It seems like it's a good question, but I think I'm reading it too quickly. So I think Katie covered this, but just to be clear, because it comes up a lot, you do not need to enroll the home of the doctor. If the doctor is calling from his or her home, that does not need to be enrolled on the 855 form. And there was a Q&A from CMS, that's acronym heavy, that came out in March that said you do. That was wrong, I think, when it came out, because it was pretty clear that if you're doing a temporary location, doesn't need to be enrolled. And CMS has come around and said, no, you don't need to enroll physician offices. You don't need to physician homes. You don't need to, on your 1500 form, put the doctor's home address in order to bill.
I'm sorry,
go ahead, Katie.
So the question is, if something isn't an actual Section 1135 waiver, but is a flexibility granted in the interim final rule, does that mean we need to bill with condition code disaster related? Does that mean we don't need to bill with condition code disaster related? I think that if you are just availing yourself of the flexibility that CMS is offering in its regulations under the final rule, you don't need to add any condition codes unless you've been specifically instructed, like in the modifier 95 situation.
And what you said made sense to me, but yeah, that sounds good to me. I know there are several more questions here, and I apologize that we're not going to get through all of them. I don't know yet what the future is hard to say. I mean, we may do another one of these in the next week or two. We don't know yet. If we do, we will try to whip through some more of the questions we didn't get to. And in the meantime, I just want to thank you all for putting up with us. Actually, I think there was one SBA question, Margie. I don't know if you saw it or knew the answer.
Yeah, there are a couple, so I can run through a couple of these if we still have a minute or two.
Yeah, go for it.
So one is, when determining payroll costs, does the group healthcare benefits include HSA employer contributions and dental insurance premiums? I haven't seen a more extensive definition of that. I would be surprised if it wasn't intended to include those amounts. But again, we're sort of getting guidance coming in piecemeal, so I'll keep an eye out and see if we see anything more on that. Another question was about when determining the FTE amount. This person is asking if they've done some reductions already, but bring themselves back to full staffing during the 8-week period of the loan, do they count out the FTE at the end of the 8 weeks, the beginning of the 8 weeks, or an average of the 8 weeks? So the answer to this one is as long as you bring yourself back up to the full staffing by the end, they won't look at anything that happened in between. If you're not quite back to full, then they're going to take the average over the period. Let's see. There was one about the SBA size standards for revenue applying for hospitals. And so in the interim final rule that came out yesterday, it clarified people's kind of current understanding is that the criteria for this program is that you meet either the 500 employee or fewer eligibility category or the employee-based size standards that the SBA has put out. So in regulations, SBA has both revenue standards and employee size standards. And so you'd be looking only for the category related to the employee size standards, which is probably not the answer that people were looking for on that one.
So I'm going to chime in here and say, if you've got questions about any of this, you're generally free to call any one of us at Fredrikson. But if it's an SBA question, call Margie, because I know Katie's not going to answer it. I know I'm not going to answer it. There are one or two of our colleagues who can, but those should go to Margie. But generally, you can follow up with any of us. We're all trying to figure this stuff out and help through it. And if you notice something or learn of a new waiver, especially something that is given individually, feel free to shoot it to us. We always like hearing about new relaxations in the rules. So thank you so much. Oh yeah, go ahead.
One more note, David. If you sent us a question via chat and we weren't able to answer it, or you are confused and you really, really need it answered, please email one of us, because we can see some of the names in chat, but sometimes they're like email monikers, and so you can't exactly tell who it is who's asked the question.
Yeah, so we have no way of getting back to you, really. All right, well, thank you so much. We hope this was useful. Hope you can join Briar and Ryan on tax day for interoperability, and hang in there. As Howard Jones would say, things can only get better.